Bom dia a todos. Bom dia a todos, bom dia a todas. Sejam todos muito bem-vindos para a nossa sessão científica semanal, a sessão científica aqui da Fiocruz, do nosso IGM, a Fiocruz Bahia. Essa sessão que acontece toda sexta, às 9 horas da manhã, e hoje é dia 5/8 de 2022. Lembrando a todos que a sessão está sendo gravada e a partir de segunda-feira vai estar sendo disponibilizado no canal do YouTube da Fiocruz Bahia. Não só essa sessão, como todas as outras que já passaram também nesse período. E no final da sessão, todo mundo pode ficar à vontade para fazer comentários, perguntas, dúvidas via chat. Em alguma situação especial, se for necessário, a gente pode, claro, abrir o microfone também, a câmera. Hoje é com muita satisfação que a gente tem o Dr. Adekunle aqui com a gente e a nossa diretora, a doutora Marilda, com muita satisfação também, vai fazer a apresentação dele e a moderação dessa sessão. Obrigado, professora. Thank you, Dr. Adekunle. Marilda.
Thank you.
Bom dia a todos e todas. Good morning, Dr. Adekile.
Thank you. Good morning.
Today our speaker is Dr. Adekunle Adekile, who is professor of pediatric hematology at the University of Kwait and one of the coordinator of the Nigeria Sickle Cell Disease Network. Dr. Adekile work by investigating different aspects of hemoglobinopathy, especially sickle cell disease. And he was very important partner for us to make the Brazil-Africa Sickle Cell Disease Program reality. We brought 18 students from Nigeria and Benin to develop dissertation and thesis here in Brazil. We have a participation of Fiocruz, UFBA, University of São Paulo, and Unicamp in this program. It is a great honor to have you here, Dr. Adekile. I know you are in vacation now, but I really appreciate your presence here to show some of your work here, what you are doing in sickle cell disease. I would like to thank you very, very much the collaboration and our discussion, and also I know you have both Nigeria and Kwait collaboration here in this meeting. Dr. Adekile, please.
Well,
you now.
Well, thank you very much, Marilda, and bom dia a todos. So good morning to everybody. It's actually my great pleasure to join you today. I already feel like part of your team in Bahia because of the long association that we have had together. And I really have to thank Marilda for facilitating all the collaboration over the years. I also want to thank Dr. Ricardo and all the other organizers of this meeting for inviting me to give this talk. And this is the outline I intend to follow. I'm happy that Dr. Marilda has already introduced me generously, but I just want to say briefly that I've been involved with sickle cell disease for many years, since the early 1980s, when I was a postdoctoral fellow at Howard University Hospital, and I worked at the Comprehensive Sickle Cell Center. And from then, I've worked in Nigeria, starting the sickle cell clinic in Obafemi Awolowo University Teaching Hospital. And then I was a Fogarty Fellow in Augusta, Georgia, which was where Marilda and I first met as fellows, and we maintained our collaboration over the years. Currently, I'm still in Kuwait, where I head the sickle cell disease program, but I was also fortunate to be the founding chairman of the Nigerian Sickle Cell Disease Network, which is now the Sickle Cell Support Society of Nigeria. As Marilda said, I've worked consistently in sickle cell disease over all these years with many grants and publications. So what I intend to do this morning really is to outline some of the important aspects of sickle cell disease, especially in the areas of phenotypic characterization of the disease, which is still lacking, and the need for collaboration, especially South-South. As you can see from this slide, the epicenter of the disease, of sickle cell disease, is mainly in sub-Saharan Africa, where the highest prevalences are seen. Okay, and of course, Brazil is very important in the equation. Now, in the northern hemisphere, the prevalence of sickle cell disease is not that great, although it's appreciable to some extent in the United States because of the Black population. However, I believe strongly that South-South collaboration is very vital in understanding the pathophysiology and phenotypic characterization of the disease. And I'm very happy, of course, with the stats that we've had with Brazil with the Nigerian fellows who performed brilliantly, doing their master's and PhD programs in different institutions in Brazil. Now, this slide just shows the world capital market, just to show where the resources are in the world. And of course, Africa is so, underprivileged, it's poorly resourced. And that's why, for a lot of the work on sickle cell disease, we still need collaboration, with other parts of the world. And that's where the issue of collaboration with Brazil is so vital. Well, just to briefly go over the pathophysiology of sickle cell disease, we know that the basic molecular abnormality is a point mutation in the 6th codon, beta codon, where there's a substitution that leads to the replacement of valine with glutamic acid. And that causes polymerization of the hemoglobin molecule, especially as it traverses the capillaries going from the arterial to the venous end. And there's dehydration of the cells, and eventually the sickle forms are present, and they're very adherent, and they form aggregates between the cells and the endothelial wall. Then there's involvement of the white cells and platelets, okay? And there are ligands and receptors that are activated that increase the adhesion process. The other aspect of the pathophysiology, of course, is heme hemolysis related, where the heme that is released by the breakdown of the red cells activates several pathways leading to oxidative stress, arginine dysregulation, and eventual nitric oxide depletion. And the nitric oxide depletion eventually leads to dystonia of the vessels, and with eventual intimal hyperplasia that contributes to the vasculopathy that eventually leads to occlusion of the vessels. Therefore, in terms of the clinical features of the disease, almost all the systems and all the tissues of the body are affected, one way or the other. Some are more important than others, especially things like stroke, splenic abnormalities, pulmonary abnormalities, which eventually lead to pulmonary hypertension and chronic lung disease, renal abnormalities, priapism, ulcers, then avascular necrosis of the bones. Okay, so all tissues of the body are affected. And you can then imagine, of course, that the presentation of sickle cell disease is so diverse, right? And although it is a monogenic disease, we now know that several other genetic factors modulate the disease and modify the severity. Some of the better known modifiers are hemoglobin F level, the HBB or beta S globulin haplotype, then alpha thalassemia, the coexistence of alpha thalassemia. These are very important factors that modify the disease, and these have been very well reproduced in different studies, okay? And we also know that the hemoglobin F determinants include, the HBB haplotype, and then there are other unlinked QTLs, quantitative traits loci, on chromosome 2, chromosome 6, and some others. Now, in addition to these factors are also other genetic factors that may be related to the coagulation system, the endothelial cell function, the inflammatory mediators, red cell membrane. So there's a whole host of polymorphisms that are not directly linked to the HBB that all influence the disease, okay? And so these are what make the study of sickle cell disease very fascinating. Now, in addition to all these genetic factors, there are also environmental factors to consider. Okay, so therefore, we know that the phenotype of sickle cell disease is highly heterogeneous because of the diversity of these genomic modifiers in different populations. And that's why it's so important that if you want to unravel the complexity of the pathophysiology of the disease and the natural history of the different sickle cell phenotypes or complications, we must have collaborative studies across ethnic groups and regions. Hence, we need this South-South collaboration, as I've mentioned. Now, just to let you know again why it is important to have patients from different backgrounds, if we just focus on haplotypes alone. Now, if you take Nigeria, for instance, most of your chromosomes will carry the Benin haplotype, okay? And most of the patients will be homozygous for the Benin haplotype, so they will be Benin, okay? There are very few of the other haplotypes. Now, if you now look at Brazil, most of the chromosomes carry the CAR or the Bantu haplotype, okay? There are a few of the Benin and others. And then if you look at Kuwait, again, most of the chromosomes are Arab Indian haplotype. Therefore, if you take these three populations, the patients are almost homogeneous, okay? Therefore, if you want to study the influence of haplotype on severity or the influence of hemoglobin F on sickle cell severity, if all your patients are coming from Nigeria, you don't have that diversity to be able to actually show, the influence of that one factor. The same thing if you're studying only Brazilian patients or only Kuwaiti patients is the same thing. So that to now get a good benefit of, if you want to take care of the confounding factors or whatever, you really need to collaborate across borders. Now, I put Oman here because Oman is very unique in the sense that it's the only country that I know where you have the three of the different haplotypes, Benin, Arab India, and the Bantu or CAR, that are in appreciable frequencies, okay? So they are in a better position, for instance, to look at their patients and see the diversity right in their own centers. Now, alpha thalassemia, like we said, influences sickle cell disease appreciably. And it seems to be, when you have the minus 3.7 kb deletion, which is the alpha thal 2 determinant, in Nigeria, Kuwait, and Brazil, it's almost the same kind of prevalence that we have. What distinguishes Kwait from the others is that in addition to this deletional alpha thal determinant, we also have non-deletional alpha thal determinants, which increases the overall frequency of alpha thalassemia in Kuwait. So these are things that you need to bear in mind in understanding the diversity of the kind of patients you are dealing with. Okay, so now the next few slides will be devoted to the situation in Nigeria. As we all know, Nigeria is a big country in Africa. It is the most populous country in Africa with a population of over 200 million. And when you realize that the prevalence of sickle cell disease in the newborn is close to 2%, so you can imagine the enormous numbers of patients that we have to deal with. And that's why we always say that Nigeria has the highest burden of sickle cell disease in the world. And for a long time, it was very difficult to coordinate the care and to have a good voice to represent the sickle cell disease population in the whole country. And that's why some years back, especially, exactly in 2010, we formed the Nigerian Sickle Cell Network, which eventually was registered as the Sickle Cell Support Society of Nigeria. Okay, and that network has been in the forefront of policy making, advocacy, and several other things in Nigeria. And the way it's structured is that there's an executive committee at the center, but then we have zonal representatives in the 6 geopolitical zones, which organize and monitor activities in their zones. And the important things in terms of the objectives that have been carried out is advocacy, building national awareness through education campaigns to reduce the stigma, to provide correct counseling, and improve individual, family, and community support. And of course, we have to liaise with the local, state, and federal governments, agencies, and build support, within the community health programs in the different parts of the country, and organize regular conferences and workshops for all interested parties. And we also provide an umbrella for all other groups, because there are so many governmental, non-governmental, religious, cultural, different societies that are geared towards sickle cell disease or oriented towards the sickle cell disease. So we tend to provide an umbrella for all those organizations to liaise with other stakeholders, government or non-government agencies. Okay, and we've been pushing for a national sickle cell disease policy, and I'm happy to say that this has gone far now. The Federal Ministry of Health has bought into all this, and different policies have been formulated, and not only at the federal level, but at the state and local government levels. And we encourage newborn screening programs and the establishment of comprehensive sickle cell centers. Of course, we need capacity. Okay, so we have been liaising with internal and external funding agencies. We have been conducting training and other programs within the country, and we try to establish partnerships both within and outside the country. And many of our members have been trained in different parts of the world. And again, I must acknowledge what has been done through the Fiocruz in Brazil for training some key people from Nigeria. And then these are the research priorities, newborn screening, and because of some of the difficulties to reach all newborns born in the hospitals at the right time for screening, we've been encouraging integration of screening with immunization programs. And because of the poor resources, we have not been able to have robust or ongoing programs using sophisticated equipment. And so we have been trying, the point of care screening kits, which have come in very handy. And there are a number of publications from, in that regard. And then we looked at the issue of penicillin prophylaxis, malaria, and other infections, hydroxyurea, trying to encourage the use of hydroxyurea. We are studying what are the barriers to proper utilization. And then, of course, the natural history of the disease in terms of genotype, phenotype studies, looking at candidate genes and other genetic associations. And we are now trying to pursue stem cell transplantation. There are 1 or 2 centers in Nigeria developing capacity for this, and we're also looking into gene therapy. In addition, consultation with other agencies. Well, as you can imagine, there are so many challenges. The one is that we have a huge population of patients, so it's very difficult to organize the care, because of the poor infrastructure and personnel and other resource shortcomings. Okay, so that's one of the major challenges. And then, of course, in terms of infrastructure, steady electricity, other equipment, specialized facilities and staff are all that we still need to develop. So this is an ongoing issue. Okay, so after all this, I can boldly say that Nigeria has probably the most sophisticated, the most robust network, sickle cell disease network anywhere in the world. We now have collaborating centers all over the world, and these centers, these 23 centers that I've shown here, this was about 6 years ago. So there are a lot more centers, and these are centers based in tertiary and secondary institutions where we have trained sickle cell experts, where there are laboratory facilities, and they are all linked, you know, in the network. Okay, so the network in collaboration with other countries is in a consortium, which is a Pan-African consortium now. And Nigeria in particular now has a database of almost 6,000 well-characterized patients, you know, in an electronic database that can be accessed, you know, with data that are readily available, so that if you want to collaborate with any of the centers, these are things that you can access. Okay, so this is going to go a long way to facilitate collaborative research within and outside the country. Okay, so that is the Nigerian aspect of the presentation. I will now go over to the Arabian Peninsula, and I've been based in Kuwait for the last almost 30 years now. And this Arabian Peninsula has the most diverse sickle cell disease in the world. And that is because if you realize that civilization, human civilization, actually started in the Middle East, okay, around the Gulf area, okay, and there have been lots of invasions, wars, trade, you know, from the north. You know, Alexander the Great, you know, and his army camped here for many years in the BC period. Then from the east, from the Indus Valley, Silk Road, and all the people have interacted. And then from the south, you know, East Africa and Oman, you know, have been in contact for many, many years. And for a long time, the Emir of Oman was also the ruler of Zanzibar. So there had been trade and intermarriages, you know. And then from the west, you know, from North Africa and West Africa, there have been contacts for centuries. So this makes the gene admixture in the Arabian Peninsula very fascinating. Therefore, in terms of sickle cell disease, we see all the haplotypes, you know, the Arab India haplotype, Benin haplotype, the Bantu in different, you know, frequencies. Then the hemoglobin F, of course, with the Arab India haplotype, there's very high fetal hemoglobin. But then with the Benin haplotype and the Bantu haplotype, you know, there isn't so much, you know, hemoglobin F expression. Therefore, we see different spectrums of the disease, severe, mild. And interestingly, too, there are so many compound heterozygotes, you know, sickle beta thalassemia. In almost all the groups in the Arabian Peninsula, S beta thal will form about 30 to 40% of your total sickle cell disease burden. We do see SD, we see SO Arab, and then we see SE. And then, like I alluded to before, there's a high frequency of alpha thalassemia trait. Interestingly, I don't know how many of you are familiar with hemoglobin S Oman. Hemoglobin S Oman, in addition to carrying the sickle mutation on the same chromosome, it also has the hemoglobin O, you know, mutation, which is the lysine valine substitution in beta 121 position. So it has two mutations on the same beta chromosome. Therefore, if you inherit just one gene or one allele of S Oman, you present with severe sickle cell disease. So it's like a dominantly inherited sickle cell. It's the only known mutation that behaves that way. And it is found only in the Middle East, especially in Oman. So therefore, working with sickle cell disease in the peninsula gives you a good insight into different aspects of the disease. Okay, so there are so many lessons to be learned in working with the sickle cell in that region. Now, this is one of the earliest publications on sickle cell disease from the region, and this was from Kuwait in 1970, where this Dr. Ali noticed that he was seeing a few patients who were adolescents or adults, incidentally found to have high sickle cell percentage on electrophoresis, but in addition, they had high levels of fetal hemoglobin. And for a long time, they were not sure whether this was actually sickle cell disease or something else, or how to describe it, until, of course, most studies from Saudi Arabia show that, in fact, many patients in eastern province of Saudi Arabia also have the same kind of pattern. And from our own studies in Kuwait, we have found out that if you look at the hemoglobin F level from soon after birth to adults, we find that in the first 2 to 3 years of life, hemoglobin F is above 30%, okay, on the average. And by the age of 3 or 4, then it falls, and it remains about 20 for the rest of the patient's life. When all the cross-sectional studies that we have done from Kuwait has shown that the average or the mean hemoglobin F is about 20 to 22%, okay? Now, what is the implication of that? If you have, most of your patients have this very high fetal hemoglobin. So how do they present? What are the kind of complications that they have? What do you see? Okay. And we started a sickle cell registry in Kuwait some years ago, and we've looked at, our patients as a whole, including pediatric and adult patients. And interestingly, the most common complication that we see is gallstones. Although hemoglobin is usually high, the average hemoglobin in our patients is about 9 to 11% grams per deciliter, okay? So, and then they don't hemolyze, we don't see hemolytic crisis that often. So why do they have gallstones? Well, a lot of that can be explained because they also carry the Gilbert's phenotype, okay, in the UGT-A, enzyme, okay, which produces or predisposes to hyperbilirubinemia, which generates the gallstones. The important problems, in terms of morbidity that we have would be splenic sequestration, recurrent splenic sequestration. Although you see sequestration in children, young children in Africa or the US, and I suspect in Brazil, but in Kuwait, the sequestration occurs in older children and even adults, okay? Now, next to that, the biggest problem is avascular necrosis of the femoral head. And we've done longitudinal studies in Kuwait. In children, the frequency of AVN is about 25 to 26%, whereas in adults, it's close to 50%. So this is a huge problem, and we still don't know all the factors that predispose to it. It's not related to alpha thalassemia. Hemoglobin F, at least within our patients, doesn't seem to influence it that much, okay? Then we do see acute chest syndrome, but it tends to be relatively mild, or few patients may end up in the ICU, they may need ventilation or exchange blood transfusion, okay? Now, the things that are interestingly not common will be things like stroke. We don't see stroke. Stroke would probably be in less than 1% of patients, either adults or children, okay? We don't see priapism, and we have not seen any case of leg ulcer, okay? Okay, now, interestingly, if you look at the different age groups, what we found out that almost all the complications or all the severe features are seen in adults, above 16 years, okay? And if you remember, and I think we'll come back to this from time to time, is that in the early age of our patients, with the very high fetal hemoglobin levels that they have, it kind of protects them, okay, so that the vasculopathy that leads to a lot of the complications develops very slowly, okay? And that's why sickle cell disease is more of a problem in adults in Kuwait than children, okay? And then when you look at this SS and S-beta thal, you know, there are some things that are more common in S-beta thal, especially issues dealing with the spleen, okay? And maybe acute chest syndrome. But the others, like AVN, is probably more common in SS. Gallstones is about the same, okay? Yeah, so, and sickle S-beta thalassemia is very fascinating because we tend to talk about S-beta plus and S-beta 0 thalassemia. Now, the S-beta plus just means that they're still producing some beta chains, okay? But the two beta thalassemia mutations that are associated with sickle cell in Kuwait are I don't know how many are familiar with this, IVS 1110, okay, and IVS 15, which are very severe beta thal mutations. Therefore, our so-called S-beta plus thalassemia also usually tend to have a severe phenotype. Okay, so having said that, you know, we say that our sickle cell patients have uniformly high fetal hemoglobins from about 15 to more than 30%. The patients do not present, they're usually asymptomatic in the first 3 to 4 years. So most of my patients in Kuwait would have their first crisis at about 4 to 5 years of age. We don't see bacterial infections commonly, and that's because the spleen remains functional. You know, up to adulthood, 75% of the patients will have very good or partial spleen function when you do colloidal nuclear uptake tests, okay, when you do the spleen scans. Stroke is not common at all. Now, silent brain infarcts are very interesting phenomenon because we did brain MRIs on a longitudinal basis for our sickle cell patients, and in children, silent infarcts are seen in less than 3%, whereas in adults, we see it in about 20%. And I don't know if you are familiar with the literature on silent brain infarcts. Now, publications from the US and other parts, and maybe also from Brazil, show that silent brain infarcts are more common in children, especially up to the age of 16. And after the age of 16, they are uncommon. So the reverse is the case in Kuwait. We don't see silent infarcts in children, but we see them in adults, which again points to the low rate of vasculopathy in patients with high fetal hemoglobin, such that many of these features that you would otherwise see early in life are being seen in adults, okay? Now, priapism and leg ulcers are very uncommon. Okay, now, as I said before, because all our patients in Kuwait have high fetal hemoglobin, so it's been very difficult for us to actually find out what is the role of fetal hemoglobin in these patients, because we don't have a denominator group that have low fetal hemoglobin to compare to those with high fetal hemoglobin. And because of that, in the last 2-3 years, we started a collaborative project between Kuwait and Oman. And as I mentioned to you before, Oman has, you know, patients with low fetal hemoglobin and a few with high fetal hemoglobin. So this is an ongoing project, by the way, so we are still collecting data, but we quickly analyzed some of the data in the last month or so. And when you look at all the patients, this row is all the patients, both Kuwaiti and Omani. So we have 144. So these are the Kuwaiti patients alone, and these are the Omani patients alone, and these are all the patients below 16 years and above 16 years, okay? And when you look at, I know, you know, this may not be very clear, you can't go through all this data, but all the hematology are actually similar in terms of the hemoglobin, WBC, platelets, and all that, and LDH and bilirubin. The only difference really, or statistically significant difference between the Kwaitis and the Omanis is the fetal hemoglobin. Again, here, the mean in Kwait is 22.4. In Oman is 12.1, okay? And, among those below 20 years and 16 years is 20, and here it's not really significant. So what we now did was to classify the patients, trying to classify them in terms of severity and looking at the frequencies of pain episodes, blood transfusion, and acute chest syndrome, So how many episodes they had in the last 1 year. So we now generated the mild, moderate, and severe subgroups. Okay. Again, I don't want to go through all the data, but when you look at pain, transfusion, and acute chest syndrome, and you look at all the patients, those below 16, those above 16 for each of these phenotypes, and then we did chi-square and other statistics. Now, the important thing is that in all the patients, the Omani patients had more pain episodes, more blood transfusions, and more episodes of acute chest syndrome. Okay? But then, interestingly, when you now look at the age groups, below 16 years is when it is really very significant, in the sense that Omani patients below 16 years are the ones that have more pain, they're the ones that have more transfusions, okay? And between the pain and blood transfusion, when you look at the adults, those above 16, there are no differences, no significant differences, okay, in terms of frequency of pain, frequency of blood transfusion, or acute chest syndrome, okay, which again buttresses the fact that hemoglobin F is only or significantly important in the younger age group, okay, who have the low rate of vasculopathy, okay. Now, without us having this comparison between Kwaiti and Omani patients, we will not be able to demonstrate that, strongly, okay. Now, but the interesting thing, again, is that when you look at both the Omani and the Kwaiti patients, we don't, in this study that we are doing so far, we have not seen any case of stroke, overt stroke. We have not seen any case of priapism, and there's no case of leg ulcers. Whereas in the literature, you will see stroke in 11% of patients, especially in childhood. Priapism has been reported in up to 35%, and leg ulcers from 25 to 75%. Now, we're not seeing it at all in both of our groups of patients, Kwaiti and Omanis. Even among the Omanis that have low fetal hemoglobin. Okay, so why is it that we're not seeing leg ulcers in Omani patients? Why is it that we're not seeing stroke? Why are we not seeing priapism? Okay, so these are still questions that need to be answered. And that's why I'm saying that although we made progress in terms of the treatment of sickle cell disease, we're doing gene therapy, we're doing so many things, we still do not quite understand the pathophysiology or the natural history of the disease, okay? So let's just focus, because we can't cover all the areas, let's focus on stroke and transcranial Doppler studies in Gulf Arabs, okay? Now, there was this article, which is fairly recent, which is a review article of stroke in Asian patients in general, Asian patients with sickle cell anemia, okay? So they did a systematic review and meta-analysis. And so many studies were included from Oman, from India, from Kuwait, from Saudi Arabia, these are all Saudi, from Turkey, from Lebanon, and so many places. Now, what I just want to point out is that the overall frequency or incidence of stroke, when you look at the Gulf countries, is very low compared to some of the other countries in Asia. And we started to think that maybe there are some other factors in the region, there may be some other genetic factors in the region that may be protecting against stroke, and not just limited to the high fetal hemoglobin. Now, this is another study. I don't have the title of the study here. From Saudi Arabia, from Saudi Arabia, looking at different complications. And this study was actually done to look for patients that qualify for stem cell transplantation. So they were looking at patients with recurrent pain crisis, acute chest syndrome, stroke and recurrent pain crisis, severe recurrent crisis and stroke. This was acute chest syndrome. The acute chest syndrome and stroke and all that. And then they looked at the Southwest province and the Eastern province. And the difference between the Southwest and Eastern province is that is the Eastern province that carried the Arab India haplotype with high fetal hemoglobin. The Southwest patients usually carry the Benin haplotype with low fetal hemoglobin. So if you just look at this column for a minute, the less than 14 years, and all these variables or all these factors, among children, 0, 0, 0, 0, 0, 0, 0. None of the patients who had high fetal hemoglobin had recurrent chest syndrome or stroke and all the other things. Okay, now if you compare to Southwest, so there were a few, but if you look at stroke in children in the US or Nigeria or any other place, the prevalence of stroke in this age group will be like 7 to 11%. It's only 1%, okay? And even above 14 years, it's just 7.4%, and here is 2.8%. Again, when you see figures like this, it's telling you that it's not just fetal hemoglobin. If it was just fetal hemoglobin, then this should be much higher than this, okay? So something is going on that we don't know yet. So we've done transcranial Doppler and brain MRI in some of our children with sickle cell disease to actually document what kind of velocities you would demonstrate in the cerebral vessels. So this was one of the earliest studies of TCD in the Gulf, which was published in 2013. This is from Kuwait. And it was not a big study. We only had 43 patients, sickle cell patients, made up of 21 SS and 19 S0, and we had 26 normal controls. Now, 5 of the patients had silent brain infarcts, okay? And the patients were similar in terms of all the other parameters, hematology and age and all that. Now, the interesting thing at the end of the day is that none of the 43 patients had high velocity. None had conditional velocities. If anything at all, they tended to have low values. Okay, this is, okay. Now, so this is the mean, the time average maximum velocity in the intracranial internal carotid artery, anterior carotid, middle carotid, and posterior carotid. Okay, and you can see that the means are very low. I mean, all within normal. As you know that the abnormal velocity will be above 200, and conditional will be between 170 and 200 centimeters per second. Of course, when these were compared to the normal controls, these values tended to be significantly higher than in controls. But in terms of the STOP guidelines that we use to classify the risk for stroke, none of our patients qualified. And then when you look at publications from different parts of the world, okay, USA, France, Brazil, Tanzania, Nigeria, and you see the percentages of abnormal velocities that is above 200 is quite significant in most of the studies until you get to the Gulf. So this was a study from Oman. This was our study from Kuwait, okay? And we did not find any conditional, they found a few conditional cases. Okay, so again, we were not sure whether this was what we were seeing was related to fetal hemoglobin. And then we now decided to extend the study. So we now gathered data on 415 sickle cell disease patients from 4 countries, Kuwait, Iraq, and Iraq, many of their patients have the benign haplotype with low fetal hemoglobin. The same in UAE, it's a mixture of high and low fetal hemoglobin. And then we we collected more data from Oman, okay? So of all these 415 patients, again, in all of them, there were no abnormal values. Not one patient had high velocity, that is above 200 centimeters per second. And there were a few in this study, 3.1%, all from Iraq, that had values between 170 and 200. Okay, so what do we make of this? It's like we know that gall and stroke is relatively uncommon. TCD is generally normal. Okay, and some of it might be due to the hemoglobin F, especially in early life. Okay, now, but we do not think it is haplotype dependent, because patients with other haplotypes from Saudi, Iraq, Oman, all don't have high stroke prevalence. So the question is, are there other protective or genetic factors? We don't know yet, okay? So my last few slides will be addressing the question of hemoglobin F modifiers. Because and this was published recently. Now, what we have noticed is that, and this was first reported, I think, from Saudi, the few patients that have the Bantu haplotype or the Benin haplotype in Saudi, okay, they have fairly high fetal hemoglobin levels, much higher than you will find in African patients with the same haplotypes, okay? As most of in the audience would probably know, that we've always thought that hemoglobin F level or expression was dependent on the G gamma globin gene in the HBB, okay? That is the XMN1 site in the -158 position. But there are other quantitative trait loci on chromosome 2, on chromosome 6, that have been shown to be very significant in terms of their contribution to the overall expression of your G gamma or fetal hemoglobin. Anyway, so we've looked at 126 single nucleotide polymorphisms in these 3 loci, and we looked at 237 patients. So this was quite a robust study. And what we did, which was quite interesting, is that among our patients, this was kind of distribution of fetal hemoglobin. So we have a few patients that would have hemoglobin F below 20%, and we have patients at the other end that had F levels above 30%, and then we have the middle, 20 to 30%. So we grouped these 237 patients into these 3 groups, F1, F2, F3, corresponding to low or relatively low, relatively high, and the middle zone, to see if we could segregate certain polymorphisms into these three groups, okay? And again, I don't want to bother you because, these are the SNP IDs and, so many other factors and statistics, and this is all bioinformatics. But at the end of the day, there were certain SNPs that were more important at one extreme, especially the F3 group, that we call the high F expressors, okay? And without bogging you down too much, what we found out is that now these colors represent the different hemoglobin F groups. Green is F3, that is the very high level, okay? The blue is, we merged F1 and F2 just for ease of identification. And we found out that it is the SNPs in this region of chromosome 6 that are more associated with high F expression, okay? So our hypothesis now is that this chromosome 6 region is playing a vital role in increasing your fetal hemoglobin expression to very high levels. So what we now have to prove is to study patients from other ethnic groups with other haplotypes and see how many of them have these SNPs, okay, or do not have it, to buttress our hypothesis that these are mainly associated or may be associated with very high expression. So that's the kind of study that we can't do in Kuwait. We really have to collaborate with other groups. And we are carrying out this same study now with our Omani patients, okay? Okay, now, just the very last couple of slides, just to talk very briefly about avascular necrosis of the femoral head. As I said, it defies the hemoglobin F, amelioration, because in spite of the hemoglobin F, our patients in Kuwait are very notorious for avascular necrosis of the femoral head, okay? And we have found out that it's not related to the hemoglobin F, it's not related to alpha thalassemia, so we don't really know what are the predisposing factors. So we're now carrying out some genomic studies looking at bone morphogenic protein, the annexin and clotho that have been associated with osteonecrosis in other studies. In addition to that, we're looking at a whole slate of cytokines and pro and anti-inflammatory cytokines and some chemokines. And this study is ongoing, but from the preliminary analysis we've done, it looks like some of these cytokines are playing an important role, but we'll see at the end of the studies what we'll find, okay? Okay, so in concluding, I think you will agree with me that there is still a lot to learn about the phenotype and the natural history of sickle cell disease, and that there are compelling reasons why we need to have collaborative studies between different countries and between different ethnic groups. One advantage, or one thing that I've done in the last 30 years is I've been collecting DNA and serum samples. And right now in the biodepository that we maintained in my department, we have well over 5,000 DNA samples and serum samples from very well characterized patients, with sickle cell disease, alpha thalassemia traits, hemoglobin H disease, and transfusion and non-transfusion dependent beta thalassemia. And I'm hoping that this can form the basis for doing translational genomic studies, comparing our patients with the background or the genomic background of Kuwait, to compare them with Brazilian patients and Nigerian patients. Okay, so that's my last slide. So I really just want to again thank you for giving me this opportunity to make this presentation, and I look forward to the discussion and any questions. Thank you so much.
Thank you, Dr. Adekile. It's very, very nice, your talking. And let me see, we have some question here. People, it's, let me see. We have Ricardo, is talking about collaboration. Ricardo also is PhD student.
Yes.
He's in University. Isadora, give congratulations and talk about very interesting the Sickle Cell Disease phenotype in Kwait and the presentation in dominant SOMA haplotype. Alan, thank you. And Alan asked some question here. It's really intriguing. Okay. Did you rates of stroke and the other symptoms in the Brazilian population bring any insight? Yes. Yeah. Considering that it's very ethnical mixed, similar to the Arab.
Yeah. Well, if I can just address that briefly, I think when we have mixed populations, like in the Gulf, Arabian Gulf, for instance, and Brazil, that just tells you again that we need large numbers of patients, to be able to study the different factors that may be important. And that has been the drawback of genomic studies. Because when you do a genomic study limited to a small group of patients, it becomes difficult to translate it to large groups. Because if you just do piecemeal studies, it's very difficult to reproduce what the other person has done. And that has been the bane of this kind of studies. And this, again, just tells you that we really need to collaborate and have larger groups of patients to study.
We have another question from Vitor Fortuna.
Yes, that's right.
Congratulations, Dr. Adekile, for the brilliant and welcoming presentation. And he has two questions.
Yes.
Have you investigated the markers of vasculopathy and inflammation in sickle cell population in Nigeria and compare them to those in the Arabian Peninsula, Kwait and Oman?
Yeah, well, thank you so much. Again, this is a very important question and line of thinking. We've looked at some markers of inflammation, especially cytokines, TNF alpha, TGF, and so many other things. And we know that there's low level inflammation, in our patients. Okay, but like you said, I think we still need to compare. And now there are some other very fascinating, markers of inflammation. And I've seen some studies from Brazil, and I think Dr. Latunya from Nigeria also collaborated with its colleagues in Brazil to look at some markers of inflammation. So this is an area really that needs to be followed up. This is an area that we can, again, work on. It's very important. Thank you.
Vitor has another question here. You mentioned that patients with high hemoglobin fetal level had some vasculopathy. Are there any prognostic biomarker that could be inversely associated between hemoglobin F and vasculopathy in this patient?
Yeah. Well, again, I think it's just the same thing that I've said. We have not done enough, we've not looked at enough markers. And I think this whole concept of low vasculopathy in our patients is fairly new, so not much work has been done at all. And these are areas that we can develop and, work on.
Ok, Dr. Manuel Barral, congrats, believe. And Nohan, congratulations, Dr. Adekile, many congratulations about your talk, Dr. Adekile. And I think we have only this question.
Yeah.
And this is very interesting, Dr. Adekile. And we can compare our patients with the Saudi Arabian patients. I think will be very interesting for us. And continue our collaboration. This is very interesting. And we have one master student. He is working and sequencing the haplotype of KTL. This that you make in the end.
Right.
I
Very
think
good.
Yes, will be very interesting. Compare our patients.
Absolutely. That would be fantastic.
Yes.
Yeah.
And about did you try to make some in this clinical, because we have a Dr. Stenberg paper that we make the clinical subphenotype. Did you publish about this clinical phenotype of
Yes.
Saudi Arabian patients?
Oh, yes. We have a few papers on the clinical phenotypes. One or two were actually published in hemoglobin, and I believe another one was published in pediatric blood and cancer. Looking at the clinical phenotypes of our patients and the different frequencies of the different, phenotypes that we see. Okay, but it's trying to do genotype, phenotype correlations that is the issue now, because I mean we have this well-characterized patient, especially like I was talking about avascular necrosis of the femoral head. We really don't know. So we know that phenotype exists, is very common, but we don't know exactly what are the predisposing factors, genomic factors. So that's one area that one would like to, still work on.
Okay. Let me see. I think we have a question. Thank you. Okay, Ricardo, it's talk about know the patients. Congrats. Okay. I think we have no question, but I'm very surprised about this difference about patient. In the Kwait, in Oman. Oman is very healing.
It's very fascinating. Very fascinating. And I still don't know what we can do to study the issue of stroke, or what really is protecting, our patients from stroke, other than just the vasculopathy that is low. So that's one area that I don't know. Maybe by the time we finish the studies we are doing now, we may have some more insights into what areas to concentrate on. But
because we have acute chest syndrome.
Yeah.
We have a stroke. Our patients, we have a lot of this clinical. Leg ulcer. Vitor is here. Vitor is studying patient with leg ulcer. And our patients have all this clinical.
Right.
Yes.
Yeah.
Yes. And about Nigeria, you talk about the sickle cell screen in the newborn.
Yes, newborn screen. Yes. Yes. Because there were a few centers where they had HPLC, for screening, but maintaining the equipment, having a regular supply of reagents, regular electricity supply, created all kinds of, challenges. So it was very difficult. And that's why, we've now been trying to use point of care kits, and some of those like Hemotype SC and one or the two others have been shown to be quite reliable, even in the newborn period. Okay, so there are more pilot studies that are going on now, and ASH has a consortium, and they're doing some pilot studies in Nigeria, for newborn screening. So when that is also finished, they will have a better insight into what kind of recommendations to make in terms of what is the more appropriate system to use, in a country like Nigeria. And it will be interesting to see, what is being done in Brazil, how you are sustaining your newborn screening program, effectively. Yeah.
Yes, I think it will be very interesting. They make this program work very well.
Yeah, yeah. And that's why I think, the conference that you talked about, if you can plan it well, we can invite, some of the people in Nigeria to talk specifically about the issues of newborn screening and the kind of challenges that they have, and then try to learn from what you guys have done, in Brazil. Yeah, that would be very helpful.
Okay. Dr. Adekile is coming. We are talking about his coming, stay some time here in Brazil in collaboration with ICE, and we can talk with the other people to make a collaboration and discuss about his a very known scientific. He's published a lot about sickle cell disease, and he has a very, very, very good experience with patients. And it will be very interesting for us, for our group, research group, to have him here with us and talk with other people. Will be very interesting. Okay.
Thank you.
And with Nigeria also, we can talk about do work with Nigeria network of sickle cell disease.
Yeah.
And who knows, we can do another program.
Sure. Oh yes. I mean, yeah. Zoom is very, good for that. You can, anytime you can have a meeting and have presentations. Yeah.
Okay.
Yeah.
People, I think we have some. Congratulations, Dr. Adekile, as a scientific and patient with social media was very important. Francisco Mateus Lima.
Yeah.
Okay, many thanks, Vitor. Many thanks for your prosperous and thriving collaboration. Vitor is working with us in our group.
Very good.
Ricardo also. Okay.
Well,
thank
you.
Very,
well, I look forward to coming to Bahia again sometime,
Yes.
Yeah.
Dr. Adekile came 3 times.
3 times, yes.
We have
I feel like,
yeah, it's a long time.
It's a long time.
And we are discussing about, let me take we are discussing about make the first Africa Brazil sickle cell meeting.
Yes.
Yes, and he will bring a very interesting topic to discuss here in Brazil.
Yeah.
Thank you very, very much, Dr.
Well, thank you. It was my pleasure.
It was a pleasure to have you here.
Yes, thank you.
Thank you.
Thank you.
Thank you, Dr. Adekile.
Thank you, Ricardo.
Nice to hear you.
Thank you.
Então, finalizamos aqui hoje, pessoal. Tivemos essa palestra excelente aqui do Dr. Adekile. E, como eu falei no início da sessão, então, teremos essa gravação disponível no YouTube, no canal da Fiocruz, a partir de segunda-feira. Tenham todos um ótimo dia e um bom final de semana. Have a good day, Dr. Adekile.
Well, thank you. Same to you.
And a good weekend for you.
Thank you.
And we are looking for forward to have you here in Brazil, Bahia, to talk about this soft collaboration also.
I will look forward to that. Thank you so much.
Thank you.
Okay.
Bye-bye.
Bye. Bye, everybody.
Dr. Adekile?
Yes, Marila.
Okay, let's discuss your coming to Brazil. Will be very interesting for us.
Yeah, I mean,